Thank you very much, sir. Can I shift the laptop, please? So I think first thing that we have learned from the experts so far is that we must know what kind of machine we have, whether it's a peristaltic or a Venturi system, because the vacuum parameters vary tremendously if it's a peristaltic or a Venturi system. In a peristaltic system, the attraction to the tip is caused by the flow rate. So you can have variable vacuum and variable flow rate, whereas in a Venturi system, a pure Venturi system, not a dual linear or a dual pump system, it's your vacuum which is your attraction, as well as it plays the role of the vacuum as well. So you may require slightly higher settings. So just keep in mind what system that you are using. I'd like to acknowledge that we do receive research grant support from Alcon. Times are changing, and now we are facing more and more of these cataracts which are, just posterior subcapsular young patients, and their visual demands, they are very active and their visual demands are very high. So we need a surgical strategy that is most importantly safe and predictable, because these are not the patients who are the most visually disabled types. So if you look at this slit lamp on the surgical microscope, you see there is practically no nucleus, or the nucleus is not at all hard at all. So you need a different way to approach this cataract compared to your normal direct or ways of chopping. I think an important thing in such cases is a good hydrodissection, because in a soft cataract, if the hydrodissection is not very good, and if the cataract is as soft as a jelly, it sometimes becomes very difficult to rotate with the chopper, because there is no mass in which it can be engaged. We must divide cataract surgery, no matter whatever grade of cataract it is, into different phases, and I think each one requires different parameters, not just for soft cataracts but even for difficult cataracts. Coming to the sculpting part, typically when we are planning to do a chop technique, what we would want to do is to have a deep but a smaller trench, because you want a good hold. You don't want a trench going very much into the periphery, because you won't have a better grip while you chop. Whereas as far as soft cataract goes, it's usually the other way around. Because these cataracts are generally not very amenable to a chop technique, you want a slightly longer trench, so that if you want to crack this trench, it's long enough and it's deep enough to actually crack it. And if you notice the parameters here, we use very low parameters here, because you want to make sure that you don't end up eating too much of the lens material. So the flow rate we typically keep between 14 to 16, a lower bottle height. So when it shows 70 on the Infinity or a gravity system, the bottle is actually placed at about 60. And the power can vary depending on the tip and the density of the nucleus. Typically we use anywhere between 20 to 40. Similar situation in the say newer machines, we would have say a flow rate of the IOP, that is a bottle height. IOP when it's 40, it's a bottle height of about 60 centimeters, a flow rate of 14 to 15, and the power between about 20 to 30. So you don't actually need a very high flow rate or a very high vacuum. The reason is that sometimes if you end up going too deep, you are unlikely to catch anything abnormal. And notice we are making a slightly longer trench here, because we want to try and crack this nucleus rather than try and chop it. So for sculpting, we would generally use a very low flow rate, so you don't inadvertently catch anything, low ultrasound power and a low bottle height. I think nucleus division is where most of us struggle as far as soft cataract goes, and this is a classical case scenario where you feel you are going to, first starting off with a trenching, then you think maybe you can chop this nucleus. So you try and first divide it, doesn't work out that well. Then you think maybe this nucleus is dense enough, then you try and chop it, it doesn't get chopped, it doesn't get divided, you end up eating some of the loose materials. And this is something that we end up very often in a neither here nor there situation. So you end up neither with a chop, you end up neither with a division, and then you end up with a nuclear bowl or an epinuclear bowl at the end of everything. So in such situations in soft cataract, my preference would be to do a 4-quadrant technique right from the beginning. So because all of us get so obsessed with chop and the various ways of chop, we feel there can be no other technique to actually divide the lens, and the 4-quadrant technique works very well. The only modification I would suggest is to do what we call as a nucleotomy technique, that is to have a very large trench on all 4 sides, so that it's easier to crack it. You may crack it at this stage, or you may not crack it. You may crack it after making all the 4 trenches. But basically you would want to avoid CHOP in these situations where the cataract density is neither here nor there. A similar case with the active fluidics, you go with the same principles, that is a low flow rate, a low IOP and a low vacuum and a low power. Notice as I'm going deep, my power went from 30 to 20. So as I'm going deep, I'm even getting more conscious that as more and more the plate becomes thin, you don't want it to go through and through. And you, like I showed, you don't necessarily need to crack it at the first stage. If your bottom plate is thin enough, it will crack or the nucleus will prolapse or it will come down. If your bottom plate is not thin enough, no matter however much you may have cracked it, it will never come to it. Now coming to the nuclear fragment removal, the most difficult part sometimes we end up is that everything starts coming very fast to the phaco tip. And it all comes out as an en masse rather than in separate fragments like we would have in a denser cataract. And that would enable us, that actually just makes us bring the fragments, even though it's soft, closer to the endothelium, which would make the cornea, even in a soft cataract, worse post-operatively on the day one compared to a very dense cataract where we have actually become masters of doing that. So you want to make sure that whatever the thinning that you have created at the plate is thin enough, and you want to divide these into different fragments so that they don't end up coming as one piece. And then you want to make sure that your parameters now change significantly. So now you need a slightly higher vacuum. So after occlusion, you need to bring the fragment to the center. And that is, in that sense, the peristaltic system has an advantage that you can keep a low attraction rate. That is so that the fragments everything doesn't keep coming straight to the phaco tip, but you can keep a higher vacuum. So low attraction, and the vacuum will build up only when the fragment is occluded by the tip. So the flow rate here is still 16 to 18, and once it is brought to the center, then the vacuum actually kicks in once the tip is getting occluded. So coming back to that case, like I said, if the plate is not thin enough, what you'll end up with is neither here nor there. And then if you notice, I've raised the vacuum, I'm trying to bring it to the center, but nothing will come because this plate in the center is very thick, so the nucleus cannot buckle down. So you need a very thin central plate in a soft cataract, otherwise the nucleus will not buckle down and you will have difficulties in doing that. So as far as fragment removal goes, this would vary, the power would vary depending on the tip and the machine that you use, but you use lower power, definitely not more than 50 for any machine. A moderate aspiration flow rate and a moderate vacuum is sufficient for most of these cases. Cortical aspiration remains the same. However, these are the patients who are likely to have posterior subcapsular cataracts or plaques. And it is actually for this very reason that we are operating these cataracts. So I think polishing in these cases does become important. And here you would want to go into what we call as the polish mode with the lowest vacuum and the lowest flow rate, that is 6 vacuum and 5 flow rate, so that even if you catch the capsule, you are not likely to rupture it. So I think pearls for soft cataract emulsification is to avoid chopping, make a game plan that you don't want to try and chop because you'll end up neither here nor there. 4-quadrant nucleotomy is definitely our preference, and low aspiration flow rate and bottle heights would be appropriate to achieve these outcomes on a post-operative day one consistently. Thank you so much.
Thank you so much.